Thanks for joining the Purview webinar for November, entitled Fostering Relationships Between Hospitals and Foundations. My name is Les Trackman. I'm the Managing Director of Purview. And what I'd like to do first is go over a few ground rules for today's session, and then I will introduce the panelists that we have for today. Well, let's just jump into it. So first off, in terms of the ground rules for today, you all will have your microphones muted. The session will be recorded and will be provided to anyone who has attended, or in fact can be used by others who didn't get a chance to attend today's session. If you have questions from the audience, please use that comments box that's on the side of your screen. Typically it's a gray screen area. And if you put questions in the comments, we will try our best at the end of the webinar to get to all of your questions that you've raised. Sometimes we don't, depending upon how many questions there are. So joining us today will be Lisa Crane. She's the Managing Director and co-founder of Crane's Crew, an organization focused on raising funds to research a cure for bile duct cancer. She's also a board member of the Mike Shane Fund, a foundation dedicated to ensuring anyone who needs a second opinion can obtain one, even if they don't have the financial means to do that. And Lisa is also a board member of the Cholangiocarcinoma Foundation, whose mission is to find a cure and improve the quality of life for cholangiocarcinoma patients. Lisa credits pursuing a second opinion with saving of her own life, and she can give us more details of that as she joins us. Also today with us is our Jim Palma, Executive Director of the Target Cancer Foundation and a board member of NORD, which is the National Organization for Rare Disorders. Target Cancer specifically promotes the development of life-saving treatment protocols for rare cancers. Target Cancer Foundation directly supports initiatives at the forefront of cancer treatment by funding innovative research, fostering collaborations, as you'll hear about today, raising awareness among scientists, clinicians, and patients. And also joining us today is Dr. Peter Rasmussen, who's the Chief Medical Officer of the clinic at the Cleveland Clinic. The clinic provides access to remote second opinions from Cleveland Clinic's world-class expert physicians from the comfort of your home. Our goal of this webinar is to provide you with new thoughts and perhaps some ideas for expanding the sharing of knowledge, the awareness, the funding, and identification of appropriate clinical care to improve health outcomes for those who might benefit from this thing that we call remote second opinions. We at Purview have found that the synergy between not-for-profits and foundations and hospitals, together with the commercial sector, can really have a positive impact on a patient's healthcare journey. First, a quick disclaimer that I've been asked to state. Purview was the impetus behind founding the Mike Shane Foundation. We have no financial interest, nor do we participate in the management of the foundation. So that's my paid for political disclaimer that I'm supposed to put through. Mike Shane Foundation is a 501c3 foundation, as are the others that we talked about today. So to start out with, Jim, I'm going to ask you to start out, and if you would, just as succinctly as you can, and I know these are your babies, so I know you like to talk about them, would you give us just a brief on both on NORD and on Target Cancer, please?
Sure. So first, thank you for having me today. I'm really appreciate the opportunity to be a part of this discussion. So I'm Jim Palma. I'm the Executive Director of Target Cancer Foundation. And just some very, very quick background. We were founded in 2009 by my brother-in-law, Paul, who was diagnosed with cholangiocarcinoma. He was in his late 30s and really encountered something that's very common among patients with rare cancers, and that's a lack of treatment options, a lack of information, a lot of isolation. So based on his experience, he started a foundation himself while he was being treated. He passed away in 2009, but since then we've kept this work going in a variety of ways. And most recently, and probably most relevant for this conversation, is through a clinical trial that we've developed that in a lot of ways is sort of providing additional data, much like a second opinion to patients with rare cancers through the development of genomic data as well as treatment recommendations. So we can talk more about that later, but that's a little bit about us. As you mentioned, I also sit on the board of the National Organization for Rare Disorders, which is the largest rare disease focused organization, and one that really represents an incredibly huge range of different very rare diseases. And of course, I have a real interest there in bringing rare cancers to the forefront of that organization as well. So thank you again.
Great. Thanks, Jim. And Lisa, if you don't mind going next, thanks again for hopping on. I know we had some technical difficulties.
I'm so sorry.
No problem. Give us a little background on yourself and on the three organizations that we introduced you for.
My name is Lisa Crane, as Les had said. I was diagnosed with stage 4 intrahepatic cholangiocarcinoma in 2010, and I was given 6 months to live. And without getting a second opinion, I would not be here today. So I'm a big proponent of second opinions, virtual opinions, remote opinions. We're all human, our doctors are human. The more specialists and eyes that can be on you and the more ideas, the better. I've had 5 recurrences with 8 tumors, but I'm currently no evidence of disease. When I was first diagnosed, I found the Cholangiocarcinoma Foundation, which is an organization that helped me navigate my treatment journey, gave me lots of support, and they do a great job of bringing specialists and patients and industry together. I'm also a board member for the Mike Shane Memorial Fund. I had the pleasure of getting to know Mike, mentor-mentee, and I'm really proud of what the Mike Shane Foundation does, providing financial assistance to patients to get remote control or remote opinions. And patients never receive a bill. They don't have to leave their home. It's all donor funded, and it's a great opportunity for a patient to be able to have a multidisciplinary group of specialists from one of their providers look at their case, review it, and give them some recommendations.
Great. Thank you, Lisa. And Dr. Peter Rasmussen from the clinic, he approaches this from a little bit different angle, but if you wouldn't mind giving us a little introduction to the clinic as well.
Great, thanks, Les. Hi, my name is Peter Rasmussen. I currently have 2 jobs at present. I continue to practice as a cerebrovascular neurosurgeon at the Cleveland Clinic, and then half my time, as you mentioned, I'm serving as the Chief Clinical Officer for a company called the Clinic by Cleveland Clinic. For many, many years, I was in charge of digital health at the Cleveland Clinic, and then 3 years ago, we formed a joint venture spin-off company called the Clinic by Cleveland Clinic in partnership with Amwell to really be a digital health incubator. Our first foray into digital health activities with this company is in virtual second opinions, as you mentioned. The Cleveland Clinic has a long history of doing remote second opinions dating back to around the year 2000. 3 years ago, we did sort of modernize the program and changed its focus a little bit to really try to increase the number of lives that we're able to touch and provide access for Cleveland Clinic expertise for patients around the world. And we've had relationship and partnership with Mike Shane Fund now, I believe, for 2 years or 2.5 years. And we're really very proud of that relationship. And I know we've been able to help a good number of patients through this relationship over the years.
Great, thank you. Great, so that's a good kickoff from giving everybody a perspective of where each of the 3 of our panelists come from. So as we approach this idea of a second opinion, obviously this is an area, as both Jim and Lisa stated, that is somewhat confusing for patients. You get into a situation where you've got either yourself or a family member who's got a potentially life-threatening situation, and you're now asking them to make some rational decisions about what to do. So from that perspective, what do you tell a patient about how or when or where to go for a second opinion or any kind of guidance going forward? And Dr. Rasmussen, let's start with you, and then we'll work our way through the panel again.
Yeah, so I think I can provide 2 different perspectives on this question, Les. So first, from a provider of second opinions to patients around the world, my message really is anytime you're facing a complex medical decision, facing significant surgical procedure, prospect of significant surgical procedure or a major life-threatening illness, and certainly, something as significant as a cancer or a rare cancer, it really behooves yourself to make sure that you are availing yourselves of the best possible expertise that you can. And fortunately at the Cleveland Clinic, we're able to practice in such an environment where we can focus ourselves down into a very narrow niche of expertise. So for instance, in my own practice as a neurosurgeon, I'm not seeing brain tumors anymore. I don't see spine problems anymore. I'm able to focus specifically on cerebral vascular disease, which really has enabled me over the last 20 years to develop a high degree of expertise and knowledge around a very narrow spectrum of conditions, which is how most of our specialists practice. So if you are to seek a second opinion at the Cleveland Clinic, whether it's in person or virtually, we make very strong efforts to match that patient to the best possible expert with the deepest expertise, which is going to maximize the patient's opportunity to meet up with a physician who's going to have the latest knowledge and have the most comfort with the wide variety of different types of treatments. So I would always encourage a patient who's facing something like that to look into a second opinion. Now, many times patients may adopt a position of, well, gee, I don't want to get a second opinion. I don't want to anger my local physician or impact that relationship at all. Now, as a physician myself and a surgeon, I want to make sure I have a partnership with that patient moving forward with treatment. And if that patient has questions in his or her mind about what my recommendations are and what the best way are to move forward, that's not a good relationship for me. It's not setting us up for success moving forward during that therapeutic relationship. And if patients express any desire to get a second opinion, I'm absolutely open for that because the patient should be completely comfortable with what's being proposed and recommended and are aligned with making the decisions and moving forward on that. And I personally, I don't know why a physician would want to be in a relationship with a patient around their treatment if they're not fully aligned and moving forward. So from a physician perspective, there really shouldn't be any fear or angst about your patient seeking that second opinion. In fact, you should welcome it. If you've done a good job with that patient and built the trust with that patient moving forward, they can get the second opinion. And obviously, if they liked you and what you've said and what your plan is moving forward, they're going to come back to you for continuation of care.
Great. Really important topics. Thank you for doing that. I would mention that the Cleveland Clinic and the clinic now itself is really one of the pioneers in this area. And the idea of the deepest level expertise is something that really is craved by the patients that we talk to that are seeking second opinions. But Jim, let's turn the perspective to you and to Target Cancer. How do you recommend deal with and when do you tell a patient that they ought to seek out a second opinion?
Yeah, so first just want to say thank you to Dr. Rasmussen for those comments. It's very good and refreshing to hear your perspective on that because that is something that we hear from patients very, very often, a fear of potentially offending their physician or feeling badly about getting a second opinion. So I think your comments are very reassuring, I think, to a lot of people to hear that doesn't need to be the case. And what we are, really recommending to people from the earliest stages is to consider the importance of a second opinion. And I think that there is a distinction that can exist between more common cancers and rare cancers when it comes to this. And I completely agree that really a second opinion can be is well advised really in any situation, but is really magnified in a rare cancer. And there's a lot of reasons for that. It may be that a patient is seeing a doctor who has really never encountered this type of cancer before, if it's something very rare, or maybe it's just something that they don't have as much experience with. So I think it really is important, especially in a lot of rare cancers where there's some very specialized care necessary, to make sure that somebody is finding a specialist and finding a multidisciplinary center where researchers and clinicians are aligned in how they're really staying on the cutting edge of how to treat a type of cancer. Of course, the question that we always get is, well, how do you find the right person to go to? How do you find that specialist? And the answer that we will always give is first connect with the relevant advocacy foundation, because chances are the advocacy foundation for any particular rare cancer, rare disease is going to have a pipeline and a connection to the top specialists in that area, or at the very least a list of who they are and what the top centers are. So it's really important to both make the connection and pass along the message about the importance of a second opinion, but also to forge a connection to a relevant advocacy group or an expert like Lisa, who can really help to guide people and help them find the right people to go to.
Great, thanks, Jim. And now, Lisa, you can, with that introduction from Jim, I know you do this every day, so can you help us out with that question as well?
Sure. So typically I think back when I'm talking to a newly diagnosed patient, I think back to my first days and how confusing and scared I was and not sure how to navigate anything. So now I tell people about Target Cancer, I tell them about the Mike Shane Foundation, I tell them about the Cholangiocarcinoma Foundation, and I think it's really important for patients to align themselves with a disease-specific foundation, especially when you're talking about a rare cancer. The Cholangiocarcinoma Foundation has a specialist map, and I really stress, even if the patient loves their doctor, to make sure that their doctor has treated cholangiocarcinoma patients before, or a whatever rare cancer that they have, and that it's a center of excellence, and that it's a multidisciplinary team, like Jim said, not a general oncologist, not a general surgeon, but specialists in that area. I've seen in the 12 years that I've been mentoring patients that patients who align themselves with a disease-specific foundation are able to seek out the best possible care, learn about clinical trials, and that can be scary. You know, when you're talking to someone who's from a very rural area, the thought of first of all, as you said, insulting their doctor, traveling somewhere, it can all be really, really overwhelming, physically, mentally, and financially. And so I try to hold their hands and help them find out, are they willing to travel? What are their goals? Just be a really good listener, and then try to, I'm not a medical expert, but try to guide them towards the center of excellence and hold their hand the whole
Great.
time. And I'm a Cleveland Clinic patient, so.
I mentioned that in the intro. Thank you. Great. So now we've set the stage for how we would potentially synergistically provide information to the patient about how, when, and where. Can any of you go into some more specifics about how you interact with some of the provider facilities to do that? How deep do you go? How much do you know about those facilities? Just in general, how does that engagement occur? And Lisa, if you wouldn't mind starting out on this one, that would be great.
Sure. So, you know, prior to being diagnosed with cancer, I ran a recruiting firm, and the whole premise of our business and my life has been about building relationships. And when I was diagnosed with cancer, I thought, well, how is that applicable to mentoring and advocating for patients? And I've learned that it really is true. It's about building relationships. And so because I'm a volunteer and I don't work for anyone specifically, I feel like I have the ability to share with patients, not as a medical expert, but places that they can go, organizations. And a lot of times it's a matter of gathering all their records, or hopefully the records are in one place, would be the first step that I help someone do. And there's lots of tools that can help a patient do that. And then looking at a patient, do they have metastatic disease? Are they really more of just somewhere they need to go somewhere that the oncologist specializes in that? Like they're not a surgical candidate. that's been determined. And so gathering records, sometimes connecting someone in an email, giving them the contact information, because a lot of times when patients are looking at getting a second opinion, they don't know where to start at that facility. So as an advocate, I think it's our job to really try to guide them and make that process easy. The Cleveland Clinic has something called the Cancer Answer Line, which does a great job of listening to all the details of what's going on with the patient and getting them to the right doctor. That's really important, the right team, the right doctor, because there's nothing more frustrating than a second opinion that you're not at the right doctor. And sometimes patients will say to me, well, I got a second opinion, and they agreed with my local doctor. And I say, great. And they go, well, was that a waste of time? And I go, no, that should give you the peace of mind that your doctor is on the right track. And second to third opinions, in my personal opinion, can be when you're first diagnosed, they can be upon recurrence, they can be down the road. I think you always have to keep all your options open, but having an advocate from a foundation or somewhere helping you navigate that, I think is important, because just calling into a main number at a hospital can be very overwhelming. And I don't know what the answer to that is. I wish more specialists at facilities aligned themselves with disease-specific foundations.
Yeah, great. Let's jump over to Dr. Rasmussen then. In response to that, obviously you've mentioned already that there's a relationship with the Mike Shane Fund. You are familiar with a lot of other foundations, I know, and you have lots of deep specialties within the clinic and the Cleveland Clinic. Is there some formula that you use for how you deal with foundations? What kind of participation or knowledge you provide between the two? How does that work at the clinic?
You know, obviously our goal is to provide access for patients to Cleveland Clinic expertise wherever they may be. And as you know, we have a relationship with Mike Shane Foundation. We also have a relationship with the Kidney Cancer Foundation and our Kidney Cancer Association. And our goal really is to create a working relationship that is going to allow patients to have that access and for us to have a sustainable program. Obviously, we're very sensitive to the price and the expense that can come out with these second opinions. Our hope is to work with the foundation in such a way that we can continue to operate moving forward in the future and provide patients and the foundation's access to the expertise that they need. Some general comments about second opinions that Lisa started talking about. I just want to amplify a little bit on. There's a lot of different second opinion programs that exist out in the country. Our goal has been to really provide patients with confidence and the hope that they need to move forward with their medical journey. And we want to make it as easy as possible. I know from personal experience, just calling into a place like the Cleveland Clinic can be overwhelming and very difficult to, as Lisa highlighted, to get to the right person. Contacting our program, the Second Opinion, we try to take a very human approach, put the patient at the center for this, and to make it as easy as possible. So we do offer the benefits of medical record collection on behalf of that patient. That can be very overwhelming to do because the medical system's complex. Medical records are stored in many different information systems, even within the same hospital, and we want to take that burden off the patient, in the time of their need. The other aspect I'd mention about a second opinion, particularly in a cancer diagnosis, is don't forget about the pathology review. Unfortunately, I can point to many examples where patients have been misdiagnosed, at least in the opinion of our experts. Particular cancers of note that are very difficult to diagnose are things like sarcoma, and particularly pediatric sarcoma. Children are actively growing, and sometimes growing tissues can be misinterpreted as actually being cancerous tissues. And it really takes an expert with deep expertise in sarcoma and or pediatrics to really make sure that you're getting to the right diagnosis. And in those situations where our pathologists have reviewed external path and we've differed in diagnosis, we don't want to put the patient in the position of one doc versus another doc and who's right. So usually we'll take the extra step and have several other pathologists independently review the pathology so that we can provide not one, but multiple second opinions on that pathologic interpretation, so the patient can feel some confidence in what our opinion is relative to the local physician. And clearly, having the correct diagnosis on pathology, whether it's cancerous versus non-cancerous, or the staging of the cancer, has dramatic impact on the treatment that's going to be recommended. So I would strongly encourage folks who are looking for second opinions, whether it's in person or virtual, to make sure that there's another opinion rendered on the pathology specimens as well.
Is there a, just jumping into that for just a second, is there a way to easily share prior pathology records with somebody at the Cleveland Clinic to get that second pathology opinion?
Well, I guess it's a definition of what's easy. There are digital pathology systems that exist, and they're very good. Unfortunately, the time commitment to digitizing the slides with current technology is twice the time commitment that is required just for old-fashioned glass slides. So what most of the nation does still is send the glass slides and the tissue blocks through the mail systems or the courier systems, which is fine, and it works very, very well. And the other thing I would mention around this, Les, is that a reinterpretation shouldn't be just the glass slides. It should start with the glass slides from the prior biopsy, but it's not uncommon. And in fact, today in with one of our patients, the patient needs additional staining on the pathology specimen. So then you need the actual tissue blocks from the initial biopsy as well to provide that actual staining on there. And obviously that's going to then require transmission of the tissue itself through the courier system. So there's not an easy way yet, but it is well established, historically based on decades and decades of work in this area. And most hospital pathology departments are very collaborative and share these specimens back quite freely. In contrast that with medical records, as you know, almost all medical records these days are digital. Imaging is almost entirely digital as well. Those are easier to transport. Imaging, through the cloud or the internet, however you want to look at that. Medical records are a mixed bag, depending upon where the medical records are stored. Some EHR systems share records with other EHR systems more or less easily. But that's one of the reasons why you would engage a program where you're going to have some assistance as a family or as a patient or a family member to get the relevant medical records without a lot of hassle.
Yep, great, thank you. And Jim, you approach this oftentimes from a clinical trials point of view. Can you give us more details of that, of how you engage?
Sure. So, as we grew as a foundation, we realized that we could contribute to research in ways that were a little bit different than solely through basic research funding, which is what we had done historically. So we developed a clinical study called TRACK, which is enrolling 400 patients with rare cancers. So what we're able to do with that study is enroll patients completely remotely without requiring them to travel or really even leave their homes or change their doctor, importantly. And by doing so, we then are able to collect their medical records remotely as well, with many, many challenges. However, it is incredibly difficult to collect medical records. Help those patients get genomic testing of their cancer at no cost, and then present that information to a virtual molecular tumor board who provides treatment recommendations back to the patient's treating physician. So really what we've tried to do is very similar in a lot of ways to what we're talking about, kind of through a clinical research study, allow patients to get, first and foremost, their genomic testing done, but then also allow for interpretation and feedback from a panel of experts who do this every week for us. So, I think it can be a good complement to a second opinion. It's not a second opinion, it's something a little bit different, but it really sort of fits into this greater conversation of how are we allowing people to gather the right data, gather really as much data as they can so that they know exactly what the best treatment is for their cancer. And in our case, then present that information to their doctor and up to them at that point if it impacts their care. So we've thought about this in a lot of different ways. It's it's not easy to know exactly how to solve for all of these issues. This is one way that we're doing it that we're really excited about. You know, and really to Lisa's earlier point about networks, I know there's a lot of other advocacy foundations listening in today, and I think one of the most important things we can do as advocacy foundations is build good networks and relationships with specialists for the diseases that we represent and with institutions as well. And that can seem daunting. That's a lot to take on, you know, building relationships nationally, especially for smaller foundations. But we are a small foundation. We really focus locally here in Boston, and that can be really powerful. It doesn't help necessarily everybody that we work with, but certainly for patients in the New England area, we can make those connections really quickly, help to skip some of that red tape that exists and that, you know, phone call to the general line at an institution trying to find the right person, and we know that that can be helpful. So I do think, you know, for other advocacy foundations, many of whom are already doing this, keeping in mind the importance of building those networks with the specialists in your area so that you can refer patients directly is very, very powerful.
Great, thank you. So my last prepared question, and then we'll take some questions from the audience, that I'd like to pose to each of our panelists is, so we do, as Jim mentioned, we do have an audience that includes a bunch of different foundations and not-for-profits, as well as many providers. Is there any advice that you would give to either of those groups, either providers or not-for-profits, on how to do this a little bit better? And I would start with you, Dr. Rasmussen. Do you have any advice? And it can go either way, either to foundations on how better to work with you, or to other of your colleagues at other institutions on how they can work with foundations.
Well, as you know, we're happy to work with foundations, and we do have some of our marketing assets deployed to work on relationships with foundations. If you're looking to create a relationship with us, you know, feel free to reach out to me afterward by email or LinkedIn. I'm happy to get you connected with the right members of our team to help bridge those relationships with us. I think if you're a provider, a healthcare system, it really behooves yourself to you know, align yourself with the foundation wherever you can. Most physicians that I talk to, you know, particularly at the Cleveland Clinic, you know, where we've got a very narrow spectrum of disease that we treat, they're more than happy to help more patients than they currently are. In my own particular instance with brain aneurysms, I'm happy to see patients all day long with brain aneurysms. So if they're, you know, if you're a physician working in this space, you're absolutely motivated to help as many patients as you possibly can in your particular area of expertise.
Great, thank you. Lisa, you want to jump into this one?
Sure. You know, I think the big question is, as an advocacy organization, are we targeting doctors and specialists, or are we targeting the institutions, or are we targeting both? And what's the best way to penetrate that? And I think when you look at like Target Cancer, the Cholangiocarcinoma Foundation, our foundation, Crane's Crew, and other organizations, we consider each other advocacy partners. I'd love to see, you know, with some of the hospitals, a page that showed their advocacy partners, so that if somebody was diagnosed with cholangiocarcinoma, they could go to the advocacy page, they could click, and it would link them to that organization. And then maybe that's a starting point where the providers, you know, at the medical facility start to familiarize themselves with these disease-specific organizations. And I think that would really help. I think the other thing is that advocacy organizations, I think sometimes people think we're competing against each other, but Jim will tell you, we are all working together for the same goal. Our goal is to help patients get better treatments, better treatment protocols, find clinical trials, push research forward, and support them. So I don't know, I was just thinking last night that maybe that's something that hospitals could do, would be have an advocacy partner link on their website that was disease specific, and that might help them build those relationships.
That's a great idea. Thank you for that.
Mm-hmm.
And Jim, thoughts on this question?
Great point. And I guess I would approach it, I completely agree, and I think that's a great idea. maybe the other thing to think about is it really comes down to networking. So for advocacy organizations, those of us in the cancer space all go to ASCO every year, and part of the yearly tradition, I guess, there is trying to find and chase down the relevant people in your space. They're probably there. So I think attending the right conferences and really meeting up with the specialists in your disease area can go a long way, because it'll give you that visibility, especially with physicians or providers who may not be aware of the really good work that you're doing, and then trying to get those providers connected to your organization through a scientific advisory board or in some other way. On the other side, for providers or even institutions, I think really becoming aware of who the organizations are in any relevant or any particular space, and not only reaching out, but especially attending their events, their conferences, scientific meetings, that kind of thing can be a really good way, not only to build a bridge to the organization, but also to the community that they represent. Really, in many cases, especially again in rare cancers, rare diseases, the advocacy organizations might be holding some of the biggest meetings on any one particular disease type, but there may be no better place to go meet all of the relevant players in that space. So that can be a really powerful way to build those connections, build trust, and really form a good working partnership.
Great. Thank you for that. So at this point, I'd like to take some audience questions. There have been a few that have been posed already. If you do have a question specific that you'd like to have answered by our panelists, please type that into the question box on the Great Panel side of your screen. But to start out with, there's a couple of questions that have been raised. And I guess the first question has been raised of how do, aside from Lisa's great idea of putting advocacy pages right on the institution site, how do patients find a disease-specific advocacy group? So how do they find these groups? It's a toss-up. Go ahead, Lisa.
Google. I think when we're, whenever you're diagnosed, I can speak from the patient perspective. I Googled it and I went, because the statistics are old. And I remember my Cleveland doctor telling me, don't read the statistics, you're a statistic of one. So I try to remember that. Believe it or not, there are some really, really strong social media pages that are patient or caregiver specific. And I'm the administrator for one for cholangiocarcinoma on Facebook. We have 800 patients, cholangiocarcinoma patients. Think about the power that's in that group, being able to share with other people, hear where other people are going, their opinions of doctors, facilities, clinical trials, and then being able to bring that information to your doctor, which is why I tell patients, having a relationship, I call my doctors my survival team, because I'm not afraid to go to them and bring information and suggest something. So I think building that relationship with your team is really important. But Google, social media, you will find the disease-specific organizations. They will pop right up.
Great.
Absolutely, and I think, again, really focusing in the rare disease, rare cancer space. Sometimes the Facebook group will precede a foundation even existing. So a lot of groups start as Facebook groups and then turn into 501c3s, which is great. But oftentimes that's the only place where you can find information. So, rare that I would ever recommend that somebody goes to social media to find good information on something. I think this is an exception because often you really can find your community there and find other people, which then leads to those connections or to a greater organization that exists as well. And Lisa, gave great examples of that, both from personal experience, but also what we see going as time goes on. So, Google, social media really seem to be the biggest ways that people will find their way to the relevant organization.
And I think Jim had, sorry, Jim. I think you hit a great point about community. I always say we've been diagnosed with cancer because it is a community. It's your medical team, it's your family, but it's so important to find other people who've been diagnosed with the same disease, not any cancer, any disease, but the same one. So I think finding those communities, you can gain a lot of knowledge, but also a lot of support too.
Right. Thank you. So one of the questions came up is from a patient, I guess a patient-related question. A patient was given the name of a specific doctor at a specific hospital to get a second opinion from. Is that an appropriate way to go about encountering that institution? And maybe we'll start with you, Dr. Rasmussen, since I would assume some of that happens at Cleveland Clinic.
Yeah, I don't think it's uncommon for patients to get specific names and recommendations, and I think that's reasonable. I just ask the patient to recognize that there may be more than one expert at each institution dealing in that area, and or that recommendation that might have been given to you might have been, the only doctor's name in that area that your local doctor referenced. So I can give an example of that. Is it's not uncommon when patients with brain aneurysms might be referred to the department chair of neurosurgery at a local academic medical center. Well, that department chair may not deal with that problem, and he or she then may recommend a different physician for that. So just have some flexibility if you're the patient, and trust that once they know what your specific questions and concerns are, that they're getting you to the right physician. And, I know some of this is, I'll leave it at that.
Okay. Another question came in about what level of hospital should they seek a second opinion from? So I guess I would translate that as, should I go to my community hospital and find the best doctor there who has some experience with this disease, or is there a different way to go about it? Maybe Lisa, you have some experience in that area.
Every patient's journey is different, and I tell them there's no right or wrong way to navigate it. It's what they're comfortable with. So if you have a patient that lives in a very rural area and maybe is seeing a general oncologist, you can suggest a second opinion, but you can tell after the first couple of conversations that they're not willing to travel. So that's a great point for the Mike Shane Memorial Fund, for them to be able to get that free remote opinion. Maybe target cancer to be part of their track study. But if a patient wants a second opinion, I think they should navigate towards someone who's a National Cancer Institute designated center, somewhere that deals with a multidisciplinary team. So you've got all those different disciplines looking at you. Because I can speak for my own disease, cholangiocarcinoma, it's a difficult disease to treat. It has a high recurrence rate, and all the disciplines fall in there. You might see a radiation oncologist, an interventional radiologist, an oncologist, but really finding that team that specializes in what you do.
Hey, that makes excellent sense. I agree completely with everything Lisa said there. And diagnoses outside. So cancer diagnosis, the multidisciplinary approach is very, very important, and that's going to lend itself to fairly large hospitals or healthcare systems or academic or tertiary care systems. For patients with diagnoses outside cancer, where one specialist may be appropriate, that physician may be working in a smaller hospital as opposed to the largest hospital. And I'll give you an example. Within the Cleveland Clinic, is that our top shoulder expert is actually located at Weston Hospital in Florida, Cleveland Clinic Weston. And that's a hospital that has about 300 beds, as opposed to in Cleveland where we're 1,500 beds. And sometimes when we match patients up to him in our second opinion program, they're asking, well, why aren't you matching me to someone in the main campus hospital? Well, it's just simply because our best expert happens to be located in Florida. So have some faith in who you're talking with. As Lisa mentioned, our Cancer Answer line has direct pipeline to who our experts are, and going to get patients to the best experts. Our program makes every effort to match patients coming through our program to the best experts inside the Cleveland Clinic.
Great, thanks. So I'm going to ask one more question that came in from the audience, and then I'll ask each of the panelists just if they have any closing remarks or any other ideas that they want to share. But are there any events or conferences that either foundations can go to where they can intermingle with other institutions, or that institutions can go to for more information about foundations? Is there such a thing?
I think there's a lot of different options, and certainly one could go to conferences all throughout the year. There's a lot of different ways that people can do this. I do think that really focusing, at least from the outset, on some of the bigger conferences can be of benefit. And a good example of this in the cancer space is ASCO, and ASCO is huge and overwhelming and very difficult to navigate in a lot of ways. But what they do a really, really nice job of is in the middle of this massive exhibit hall, right in the best spot in the house, is a patient advocacy pavilion where there's, I'm not even sure how many, Lisa, maybe 30 or 40 patient advocacy organizations who all have booths, are right by the door, and anybody can come and talk to. And it's a really, really great way to make connections. So I think that people can travel around and certainly find the conferences that are relevant to a very specific disease space. But you can also think big and really think about the ways that you can, participate in something like patient advocacy area in order to make those connections and sort of stand out a little bit among a huge group. Lisa, I'd love to hear what you think about that.
I think ASCO is great. My first time going, it was overwhelming. I agree that the advocacy lane, or whatever they call it, where all the advocacy organizations are at, is great. And I think that's a piece of what specialists and hospitals can do. But I also go back to saying that I think they should attend disease specific so that they can build those relationships with that disease specific organization, and that referrals can be made. I'll give an example. The Cholangiocarcinoma Foundation every year has an annual meeting. Patients, caregivers, industry, and medical professionals are welcome, and we're all together. So it's a great opportunity for patients to hear and meet about specialists, research, clinical trials, what's going on in the very disease-specific area, bile duct cancers. And it's a great opportunity for providers to learn about the foundation, connect. Like I said in the beginning, I think it's all about building relationships. So you go there, you build relationships. My Cleveland Clinic oncologist was not familiar with the Cholangiocarcinoma Foundation. I kept pushing. He came to the first meeting. Now he's involved. Patients know who he is. He has more knowledge about the disease thanks to the foundation. There's a International Cholangiocarcinoma Registry Network. So I think the big ASCO is important, but I think if a doctor has a limited amount of time, I think if they're treating a disease that's very specific, seeking out that foundation and finding out where their conference is and how they can build that relationship.
Great. Good ideas. Okay. So to wrap it up, I'd love to give each of you just a brief amount of time to just talk about any ideas that you have that we haven't shared today, or anything about your organization you want to make sure that the audience is aware of. And Dr. Rasmussen, if you wouldn't mind kicking that off, that would be great.
Yeah, I think the only thing we haven't really covered, Les, is the fact that I think second opinions are vastly underutilized by most patients. Whether they're seeking out an opinion, second opinion in person or virtually, it's not often happening often enough. What we're finding in our program, which is really mirrored by many other virtual second opinion programs across the country, is about a quarter of the time we're changing diagnosis, and about 3/4 of the time we're differing in opinion on treatment plan. And if you're getting to the highest level of expertise, as a patient, you're very likely going to be getting the most current state-of-the-art therapy and options available to you. So it really behooves you to seek out that level of expertise when the frequency of change, is actually that high. And from a payer perspective, sometimes, they may want to balk at, paying for that extra opinion or whatever. But what we're finding on average over time is that expert recommendations are actually costing less from a payment standpoint and delivering the patient the best care.
Great, thank you. Jim?
Yeah, I think, just to really reiterate the importance of a second opinion in rare cancers and rare diseases in general, that it can really be not seen as an add-on, but just a really critical part of an entire care plan. What I think is really also important to keep in mind is that through COVID, a lot of institutions, a lot of foundations kind of out of necessity built ways to do these types of things remotely better. And much of that is already being done through, Mike Shane Fund and other organizations. But, really encouraging people to seek out those opportunities, and also encouraging, both advocacy organizations, but also providers to think creatively about how you can integrate existing tools. If we learn nothing else from COVID, it's that we can do a lot of things from home, and we don't need to sort of stick to the way that we used to do these things, which required so much more travel and expense. So really, keep thinking creatively about how we can create those programs, but also for patients to really seek out and ask about ways that you can do things virtually or remotely that maybe otherwise would have required travel and expense previously.
Okay, thanks, Jim. And Lisa?
On the patient perspective, advice that I would give patients is to always seek out a second, third, fourth opinion. Align yourself with an organization, a foundation. Find an advocate, a mentor to help you, a community. And remember that it's your journey and that there's no right or wrong way to do it. It has to be what you're comfortable with. On the provider side, I would say my biggest piece of information would be to seek out those disease-specific foundations, maybe consider them advocacy partners, put them on your website so that they can be linked to it, and remember that we're a community all working together for the same goal: improve the life of patients.
Terrific. Thank you very much to our panelists, to Dr. Rasmussen, Jim Palma, Lisa Crane. Your participation is very much appreciated, and I'm sure our audience got a lot out of it. You now should have on the screen links to each of the organizations that we've talked about today: Target Cancer, Crane's Crew, Mike Shane Fund, Cholangiocarcinoma Organization, NORD, and of course the clinic by Cleveland Clinic. So you'll get a copy, as I said, of the slides attached to the recorded presentation. So if you can't jot these down quickly, you can get to those. A lot of good information on those sites. I also wanted to mention what's next from coming up from Purview. There's a few takeaways that you can also get from this webinar. Some of these are written documents, 8 things to consider after a cancer diagnosis, when you should seek a second opinion for your child, step-by-step guides of getting a second opinion. And then, of course, our next webinar, which will be coming up in January. We actually had this scheduled earlier this year, and we pushed it to January, but that's the special case of orthopedic second opinions. That's on January 12th, and that'll be at 2 p.m. Eastern Time. Thanks to our audience for joining us today. Thanks again to the panelists. We appreciate your time and efforts, and we'll see you again next time.
Thanks, Les.